Question 1. A 68-year-old patient undergoes an open, initial repair of a reducible, incarcerated recurrent incisional hernia located in the subcostal area. What is the correct CPT code for this procedure? A. 49,565, 49,568. B. 49,560, 49,568. C. 49,566. D. 49,565. Answer D. 49,565. The concept tested here is the correct coding for incisional ventral hernia repair, specifically identifying the key terms: open, incisional, and recurrent. The code selection is driven by the fact that this is a recurrent incisional hernia, making 49565 the correct choice, which covers the open repair of a recurrent incisional or ventral hernia, regardless of size or whether mesh is used. Mesh placement is reported separately if performity. Although the hernia is incarcerated, codes for recurrent incisional hernia repair do not typically change based on incarceration/strangulation, unlike initial ventral or inguinal hernia repairs. Remember that incisional and ventral hernias are treated the same for coding purposes, and the key is determining if it is initial or recurrent. Question 2. A patient is scheduled for a flexible diagnostic colonoscopy. During the procedure, the physician notes a small sessile polyp in the sigmoid colon and removes it using a snare technique. What CPT code F should be reported? A. 45,378. B. 45,385. C. 45,380, 45,378 to 59. D. 45,378, 45,385 to 51. Answer B. 45,385. This question tests the guideline regarding the conversion of a diagnostic endoscopy to a surgical endoscopy. The keyword sessile polyp, removes it using a snare technique, indicates a surgical procedure. According to CPT endoscopic guidelines, when a diagnostic procedure, 45378, leads to a surgical procedure, 45385, only the most extensive surgical code should be reported. Therefore, the single code for the surgical removal of the polyp by snare technique, 45385, is the correct choice because the diagnostic portion is bundled into the surgical code. Remember, the highest level of service performed through the scope is typically the only one reported. Question 3. What ICD-10-CM code is reported for a patient diagnosed with acute and chronic cholecystitis with cholelithiasis? A. K80-10. B. K81-2. C. K81-1. D. K80-20. Answer A. K80-10. The concept involves accurately classifying conditions affecting the gallbladder, specifically cholelithiasis, gallstones, and cholecystitis, inflammation. The keywords are cholelithiasis, gallstones, and acute and chronic cholecystitis, which requires looking up the combination code. ICD-10-CM guidelines provide a single combination code, K80-10, which specifically includes both gallstones and the mixed acute and chronic inflammation, without mentioning obstruction. Always look for combination codes when a condition is described by multiple associated terms in the documentation. Question 4. Which procedure involves an endoscopic examination of the bile and pancreatic ducts using an endoscope that is passed through the esophagus, stomach, and duodenum? A. Esophagogastroduodenoscopy, ED. B. Endoscopic retrograde cholangiopancreatography, ERCP. C. Diagnostic cholangiography. D. Flexible sigmoidoscopy. Answer B. Endoscopic retrograde cholangiopancreatography, ERCP. This question tests the understanding of common digestive system procedure terminology, specifically identifying the scope of an ERCP. The keywords bile and pancreatic ducts and endoscope through the duodenum are the clear clues. ERCP is a complex endoscopic procedure that allows the physician to inject contrast dye to visualize and sometimes treat conditions within the biliary, bile, and pancreatic duct systems. For example, an ERCP can be used to remove stones from the common bile duct. Here's an easy way to remember it. The C, cholangio, and pancreato in ERCP refer directly to the ducts being examined. Question 5. A 45-year-old patient with known Crohn's disease undergoes a small bowel resection with anastomosis. The removed segment includes the terminal ileum. What is the correct CPT code for the surgical procedure? A. 44,120. B. 44,140. C. 44,145. D. 44,150. Answer: A. 44,120. The concept is the proper coding for small intestine excision and anastomosis procedures. The keywords are small bowel resection and anastomosis, which points to the CPT range 44,120 to 44,130. Code 44120 is used for an enterotomy, or resection, of the small intestine with anastomosis, covering a single resection. Codes like 44140 and above are specific to excision of the colon, colectomy, which is a different part of the anatomy, making 44120 the accurate choice. When coding digestive excisions, always confirm the specific part of the intestine, small bowel, colon, or rectum, being addressed. Question 6. A patient is seen in the office for management of their established, stable gastroesophageal reflux disease, GERD. The physician provides a prescription refill and schedules a follow-up in 6 months. What is the appropriate ICD-10 CM code? A. R12. B. K21-9. C. K21-0. D. Z11-7. Answer: B. K21-9. This question tests knowledge of diagnostic coding for common digestive diseases, focusing on ICD-10 CM specificity. The key term is gastroesophageal reflux disease, GERD, without mention of esophagitis. Since no inflammation, esophagitis, is documented, the nonspecific code K21-9, gastroesophageal reflux disease without esophagitis, is the correct choice. If the documentation had mentioned inflammation of the esophagus, K21-0 would be used, demonstrating the importance of looking for the 5th character specificity. Always check if a code requires a 4th, 5th, or 6th character to define severity, laterality, or manifestation, as required by the ICD-10 CM index. Question 7. A surgeon performs a laparoscopic cholecystectomy for cholecystitis. The procedure is complicated and requires the surgeon to convert to an open procedure to safely complete the removal of the gallbladder. What CPT code, S, should be reported for the surgical procedure? A. 47,562, 47,600. B. 47,600. C. 47,562. D. 47,600, 47,562 to 52. Answer: B. 47,600. This concept relates to coding for a procedure that is started laparoscopic but converted to an open procedure. The keyword convert to an open procedure guides the selection. CPT guidelines state that when a laparoscopic procedure is converted to an open procedure, only the open procedure code is reported, regardless of the time spent on the failed laparoscopic attempt. In this case, 47600, cholecystectomy, open, is the correct and only code to be reported. The key takeaway is that the most extensive procedure actually completed, the open removal, is the service that should be reported. Question 8. What is the correct CPT code for a flexible esophagogastroduodenoscope ID with placement of an esophageal stent? A. 43,248. B. 43,235. C. 43,266. D. 43,270. Answer: D. 43,270. This question focuses on correct CPT coding for therapeutic endoscopic procedures of the upper GI tract. The keywords are EGD and placement of an esophageal stent. The code 43270 is specifically designated for an EGD with stent placement, including the endoscope and all necessary components of the procedure. While 43248 is for foreign body removal and 43235 is for a diagnostic EGD, 43270 accurately describes the placement of the stent. Remember to choose the code that most accurately and completely describes the therapeutic action performed during the endoscopy. Question 9. A 3-year-old patient presents with an initial, reducible, non-strangulated inguinal hernia on the left side. What is the correct CPT code for the open surgical repair? A. 49,500 to 50. B. 49,505. C. 49,500. D. 49,505 to 52. Answer C. 49,500. This question tests the application of age-based coding for initial inguinal hernia repairs. The key terms are initial, inguinal hernia, and the patient's age 3 years old D, which is under the age of 5. CPT code 49500 specifies the repair of an initial inguinal hernia for a patient under the age of 5. If the patient were 5 years or older, code 49505 would be used, illustrating how age affects code selection for this common procedure. Always check the introductory notes and code descriptors for age restrictions or laterality requirements when coding hernia repairs. Question 10. A physician excises 2 external anal skin tags. What is the correct CPT code? A. 46,230. B. 46,220. C. 46,250. D. 46,945. Answer A. 46,230. This question is about surgical procedures involving the anus, specifically the simple excision of skin lesions. The keywords excises, external, and anal skin tags direct you to CPT code 46230. This code specifically covers the excision of any number of external anal skin tags performed during the same operative session. The other codes listed are for internal hemorrhoid injection or more complex hemorrhoidectomies. A simple way to remember is that 46230 is the designated code for common, benign skin tag removal in the anal region, regardless of how many are removed. Question 11. Which CPT modifier indicates that a procedure or service was reduced or eliminated at the physician's discretion, e.g., a patient's poor condition forces termination of the procedure? A. -73. B. -52. C. -74. D. -53. Answer B. -52. The concept tested is the correct application of CPT modifiers for incomplete or discontinued procedures. The keywords reduced or eliminated and at the physician's discretion point to modifier -52. Modifier -52 is appended to the CPT code to indicate that the service was partially reduced or eliminated by the physician before completion, often due to extenuating circumstances like patient tolerance. Modifier -53 applies to procedures discontinued due to patient risk, while -73 and -74 are for facility/hospital reporting of discontinued outpatient procedures. Remember, modifier -52 is typically used for services the physician decides to curtail. Question 12. A patient is diagnosed with an acute flare-up of diverticulitis with a documented perforation of the colon. What is the correct ICD-10 CM code? A. K5730. B. K5720. C. K5721. D. K5732. Answer C. K5721. This question tests the coding of diverticular disease, requiring the most specific code available in ICD-10. The keywords are diverticulitis, acute, and perforation. The condition involves both diverticulitis and perforation without mention of bleeding, leading to code K5721. K5721 specifically identifies diverticulitis of the large intestine with perforation and abscess, without mention of hemorrhage. Ensure that you select a code that captures both the inflammation diverticulitis, and the most severe complication, perforation, for complete documentation. Question 13. Which of the following is the final segment of the small intestine that connects to the large intestine? A. Jejunum. B. Duodenum. C. Cecum. D. Ileum. Answer D. Ileum. This is an anatomy question testing the basic structural components of the small intestine. The keyword final segment of the small intestine is the key identifier. The three parts of the small intestine are the duodenum, the jejunum, and the ileum in that order, with the ileum being the last section connecting to the large intestine at the ileocecal valve. The cecum is the beginning of the large intestine, not the end of the small intestine. Understanding the GI tract's anatomy is foundational for correctly sequencing and differentiating CPT codes for procedures. Question 14. A patient has a recurrent strangulated femoral hernia repair performed on the right side. What CPT code F should be reported? A. 49,553. B. 49,557. C. 49557 RT. D. 49,555. Answer B. 49,557. The concept here is using the correct CPT code for a femoral hernia repair. The keywords are recurrent, strangulated, and femoral hernia. CPT code 49557 specifically describes the repair of a recurrent femoral hernia when performed for an incarcerated or strangulated presentation. Code 49555 is for an initial repair, and 49553 is for a reducible recurrent repair. Remember that for hernia codes 49,550 to 49,557, the code description explicitly covers whether the hernia is reducible or incarcerated/strangulated, so the added diagnosis often affects the CPT selection. Question 15. A surgeon performs a total abdominal colectomy with ileostomy. What is the correct CPT code? A. 44,140. B. 44,150. C. 44,151. D. 44,144. Answer B. 44,150. This question tests the coding of complex colon excision procedures. The keywords are total abdominal colectomy and ileostomy. Code 44150 represents a total colectomy, which is the removal of the entire colon, including the formation of an ileostomy, creating a stoma to the outside. The other codes are for partial colectomies 44140, 44,144, or total colectomies with an ileorectal anastomosis 44151. When coding colectomies, pay close attention to the extent of the excision, total, partial, subtotal, and the type of resulting anastomosis or stoma formation. Question 16. A patient is undergoing an EGD with ablation of 2 areas of Barrett's esophagus using radiofrequency. The physician performs a single biopsy prior to the ablation. What code F should be reported? A. 43,228. B. 43,239, 43,228 to 59. C. 43,270. D. 43,235, 43,228 to 51. Answer A. 43,228. The concept involves correctly applying CPT bundling rules for upper GI endoscopy. The keywords are EGD, ablation of Barrett's esophagus, and single biopsy prior. The CPT code for ablation of Barrett's esophagus is 43,228, which is the comprehensive surgical code. Diagnostic procedures such as a biopsy, 43239, performed during the same surgical session, even if before the main surgical procedure, are typically bundled and not separately reported. Always report the definitive surgical procedure code when a diagnostic scope converts to a surgical one, or when a minor diagnostic component is included in a major therapeutic procedure. Question 17. The patient has a follow-up visit with the surgeon 30 days post-cholecystectomy for complaints of mild, unrelated stomach discomfort. The The surgeon performs a detailed E/M and concludes the discomfort is due to gastritis, not the surgery. How should the E/M service be reported? A. E/M code EG 99213. B. E/M code with modifier -24. C. E/M code with modifier -78. D. No charge included in the global period. Answer B. E/M code with modifier -24. This scenario tests the appropriate use of modifiers within the surgical global period. The keywords are follow-up visit, 30 days post-cholecystectomy within the global period, and unrelated stomach discomfort, unrelated to the surgery. Modifier -24 is used to indicate that an evaluation and management service was performed during a postoperative global period for a reason unrelated to the original surgery. Standard follow-up care related to the surgery would be included in the global fee. Therefore, the E/M service is billed with modifier -24 to show it's separately billable because the diagnosis of gastritis is unrelated to the cholecystectomy. Question 18. A 55-year-old male is diagnosed with bleeding esophageal varices due to cirrhosis of the liver. What is the correct ICD-10 CM code? A. K7460. B. I8501. C. K7030. D. K7460. I8501. Answer B. I8501. This question tests the ICD-10 CM sequencing and combination code hierarchy for conditions of the liver and associated complications. The condition is bleeding esophageal varices, which is often a complication of liver disease like cirrhosis. In ICD-10 CM, code I8501, esophageal varices with bleeding and liver disease is a combination code that covers both the presence of the varices and the bleeding manifestation, and it implicitly points to the underlying liver disease. While K7460 is the code for unspecified cirrhosis, the ICD-10 CM tabular list directs you to use I8501 or similar as the primary code if the varices are bleeding. When reporting, always look for the most specific combination code that captures both the cause and the manifestation. Question 19. A surgeon performs a laparoscopic appendectomy. During the procedure, the surgeon notes that the appendix is perforated. What is the correct CPT code for the surgical procedure? A. 44,970, 49,000. B. 44,955. C. 44,960. D. 44,970. Answer D. 44,970. This question focuses on the CPT coding for an appendectomy, regardless of the appendix's condition. The keywords are laparoscopic appendectomy and perforated. The code 44970 is the single code used for any laparoscopic appendectomy, whether the appendix is normal, inflamed, or ruptured/perforated, because the surgical technique remains the same. The open codes, 44950 through 44960, change based on the status of the appendix, perforated or not, but the laparoscopic code does not. The condition of the appendix is reported only via the ICD-10 CM code, not the CPT code. Question 20. Which term describes the surgical creation of an opening between two previously separate organs or structures, such as a gastrojejunostomy? A. Resection. B. Ablation. C. Anastomosis. D. Excision. Answer C. Anastomosis. This is a medical terminology question essential for understanding surgical procedures in the GI tract. The key phrase is surgical creation of an opening between two previously separate organs, and the example gastrojejunostomy reinforces this. Anastomosis is the medical term for creating a surgical connection between two tubular structures, such as blood vessels or parts of the intestine. The other terms, resection, ablation, and excision, all involve removing or destroying tissue, which is different from creating a connection. Knowing this core terminology is vital for differentiating complex surgical codes like colectomy with versus without anastomosis. Question 21. What CPT code is used to report a percutaneous needle core biopsy of the liver, performed without imaging guidance? A. 47001. B. 47100. C. 47,000. D. 47,010. Answer C. 47,000. This question tests the coding for liver biopsy procedures, specifically differentiating between core and wedge biopsies and the role of imaging guidance. The keywords are percutaneous needle core biopsy and without imaging guidance. CPT code 47,000 is correctly used for a percutaneous needle biopsy of the liver when no imaging guidance is reported. If imaging guidance, like ultrasound D, had been used, an additional guidance code from the radiology section would also be reported, or the code 47001 add-on code would be used alongside the imaging guidance code if appropriate for that payer. Remember that 47,000 is a standalone code, but 47001 is an add-on code used only with an imaging guidance code. Question 22. A surgeon performs a repair of a large ventral hernia that requires significant dissection and reconstruction of the abdominal wall layers using component separation technique. What CPT modifier should be considered if the physician spends an unusual amount of time and effort due to the complexity? A. -78. B. -59. C. -22. D. -51. Answer C. -22. The concept is recognizing when CPT modifier -22 for unusual procedural services is appropriate. The keywords are requires significant dissection and reconstruction, component separation technique, and unusual amount of time and effort due to the complexity. Modifier -22 should be appended to the primary procedure code when the service is substantially greater than typically required. This alerts the payer that additional documentation justifying the increased reimbursement should be reviewed. Remember that documentation must clearly support the increased effort, time, or technical difficulty to use modifier -22 correctly. Question 23. A patient is seen for a screening colonoscopy. A polyp is found in the transverse colon and removed by hot biopsy forceps. The correct CPT code is 45,384. What is the primary diagnosis code for this encounter? A. D12-3 polyp of transverse colon. B. Z12-11 encounter for screening for malignant neoplasm of colon. C. Z12-11 D12-3. D. Z12-12 encounter for screening for malignant neoplasm of rectum. Answer B. Z12-11. This question tests the ICD-10 CM guideline for coding encounters that start as screenings but result in a finding. The keywords are screening colonoscopy and polyp is found. The primary diagnosis code must still reflect the reason for the encounter, which was screening, making Z12-11 the appropriate first listed code. According to ICD-10 CM guidelines, when a screening results in a positive finding, the Z code for screening is sequenced first, followed by the code for the actual finding, D12-3. The screening code Z12-11 is the essential primary code because it justifies the preventative nature of the service, which is critical for reimbursement. Question 24. A surgeon performs an open repair of a non-strangulated initial umbilical hernia in an adult. What CPT code should be reported? A. 49,585. B. 49,587. C. 49,580. D. 49,589. Answer A. 49,585. This question requires specific knowledge of CPT codes for umbilical hernia repair based on patient age. The keywords are open repair, initial umbilical hernia, and adult. CPT code 49585 is designated for the repair of an initial umbilical hernia in a patient age 5 years or older. Codes 49580 and 49,582 are for patients younger than 5 years old, highlighting the importance of age in code selection for this procedure. Always confirm the age of the patient when coding an umbilical or inguinal hernia repair. Question 25. A 40-year-old patient with cirrhosis is admitted to the hospital and undergoes a therapeutic paracentesis, abdominal tap, to relieve ascites, with removal of 4 liters of fluid. What CPT code is reported? A. 49,082. B. 49,083. C. 49,084. D. 49,080. Answer B. 49,083. The concept is correct coding for paracentesis, which is differentiated by whether imaging guidance is used and whether the procedure is diagnostic or therapeutic. The keywords are therapeutic paracentesis and to relieve ascites, which indicates a therapeutic drainage. Code 49083 is used for an abdominal paracentesis that is therapeutic with imaging guidance, or 49,082 if performed without imaging guidance. Assuming this common hospital procedure includes the necessary guidance, the code description for 49083 includes imaging guidance. 49083 is the more comprehensive choice in this common clinical scenario. Code 49082 is an acceptable alternative if documentation explicitly states no guidance was used, but 49083 is the current standard for this therapeutic intervention and covers all components. Question 26. Which ICD-10 CM category is used to report a diagnosis of chronic diarrhea? A. R19-7. B. K52-9. C. K59-1. D. K58-9. Answer A. R19-7. This question tests the classification of symptom codes in the ICD-10 CM chapter for the digestive system. The keywords are chronic diarrhea. Diarrhea, when not specified as infectious or inflammatory, is categorized as a symptom or sign and is found in the R codes. Symptoms, signs, and abnormal clinical and laboratory findings. R19-7 is the correct code for diarrhea, unspecified, when it is the primary focus of the encounter or the definitive diagnosis is unknown. Remember, if a definitive diagnosis is known, G, infectious colitis, that diagnosis code would be used instead of the symptom code. Question 27. What CPT code is used for the laparoscopic placement of an adjustable gastric restrictive device, e.g., gastric band-D, for morbid obesity? A. 43,644. B. 43,645. C. 43,770. D. 43,846. Answer C. 43,770. This question tests specific CPT codes for bariatric, weight loss, surgical procedures. The keywords are laparoscopic placement and adjustable gastric restrictive device, gastric band-D. The code 43770 is the correct CPT code for the laparoscopic placement of an adjustable gastric restrictive device and anastomosis, including the approach. Codes 43644 and 43645 are for gastric bypass procedures, not band placement. When coding bariatric surgery, it is crucial to identify the exact procedure performed, G, band, sleeve, bypass, and the surgical approach, open or laparoscopy. Question 28. A surgeon performs a total proctocolectomy with permanent ileostomy. What is the appropriate CPT code? A. 45,395. B. 44,155. C. 45,110. D. 45,120. Answer B. 44,155. The concept involves correct coding for excision of the colon and rectum. The keywords are total proctocolectomy, removal of the entire colon and rectum, and permanent ileostomy. CPT code 44155 specifically describes a total colectomy and removal of the rectum, proctocolectomy, with the formation of an ileostomy. Code 45110 is for a simple proctectomy, rectum removal, and 45395 is an endoscopic procedure. Pay close attention to the extent of the excision. The removal of the colon, colectomy, plus the rectum, proctectomy, warrants the proctocolectomy codes. Question 29. The initial segment of the large intestine, where the small intestine empties, is called the A. sigmoid colon. B. Transverse colon. C. Cecum. D. Rectum. Answer C. Cecum. This is a foundational anatomy question about the structure of the large intestine. The key phrase is initial segment of the large intestine, where the small intestine empties. The cecum is the pouch connecting the ileum, last part of the small intestine, to the ascending colon of the large intestine, and is where the appendix is attached. The other choices are further along the large intestine. Understanding the path of the GI tract helps in distinguishing between CPT codes that specify different anatomical locations, such as the cecum versus the sigmoid colon. Question 30. A physician performs an endoscopic retrograde cholangiopancreatography, ERCP, and removes a stone from the common bile duct using a basket. What CPT code is reported for the surgical procedure? A. 43,260. B. 43,264. C. 43,265. D. 43,264, 43,265 to 51. Answer C. 43,265. This question tests the coding of therapeutic ERCP procedures. The keywords are ERCP and removes a stone, using a basket, indicating stone removal. CPT code 43265 is specific for an ERCP with removal of a calculus stone from the biliary ducts. If the physician had only performed a sphincterotomy, 43264 would be correct. Since stone removal, 43265 is a more comprehensive service than the diagnostic ERCP 43260, only the surgical code 43265 is reported. When coding ERCPs, choose the single CPT code that describes the most complex therapeutic intervention performed. Question 31. What ICD the 10-CM code is used to report a patient with a personal history of gastric ulcer, now Hileti, but who currently uses aspirin regularly? A. K25-9. B. Z87-11. C. K25-7. D. Z87-891. Answer B. Z87-11. This question tests the application of history codes, Z codes, in ICD's 10-CM. The key phrase is personal history of gastric ulcer, now Hileti, meaning the current condition is no longer active. The code Z87-11 is used for a personal history of peptic ulcer disease, which includes a healed gastric ulcer. You should not use the active ulcer codes K25X unless the ulcer is currently bleeding or otherwise active. Remember, Z-codes are crucial for documenting a patient's past medical issues that may influence current care or require screening. Question 32. A surgeon performs a laparoscopic repair of a hiatal hernia with implantation of mesh. What CPT code is reported? A. 39,502. B. 43,337. C. 43,332. D. 43,280. Answer D. 43,280. The concept involves coding surgical repair of a hiatal hernia via the laparoscopic approach. The keywords are laparoscopic repair and hiatal hernia. CPT code 43280 is specifically for a laparoscopic hiatal hernia repair, which includes implantation of mesh if performed, and may also include fundoplication if performed concurrently. Codes like 39502 and 43332 are for open repairs, so the approach is the main differentiator. When coding hernia repairs, always check both the anatomical site, hiatal, and the surgical approach, laparoscopic versus open. Question 33. A 5-year-old patient undergoes an excision of an anal fissure. What CPT code is reported? A. 46,200. B. 46,083. C. 46,255. D. 46,270. Answer A. 46,200. This question tests the coding for procedures related to anal fissures. The keyword is excision of an anal fissure. CPT code 46200 is used for the surgical excision or fistulectomy of an anal fissure. Code 46083 is for a simple sphincterotomy, incision, and the other codes relate to hemorrhoidectomy or complex fistula. The CPT code description for 46200 accurately describes the definitive treatment, excision, for a chronic anal fissure. Always confirm the specific procedure performed, excision, incision, or injection, to select the correct code. Question 34. What is the main function of the gallbladder? A. To produce insulin. B. To produce bile. C. To store and concentrate bile. D. To filter waste products from the blood. Answer C. To store and concentrate bile. This is a fundamental anatomy and physiology question about the digestive accessory organs. The keyword is gallbladder, whose main role is not to produce or filter, but rather storage. The liver produces bile, and the gallbladder then concentrates and stores that bile before releasing it into the small intestine to aid in the digestion of fats. The pancreas produces insulin, and the kidneys filter blood. Understanding the basic function of the gallbladder is critical for understanding procedures like cholecystectomy. Question 35. A surgeon performs an open small bowel resection, 44120, and a complex closure of the abdominal wall layers, e.g., component separation, to repair a massive defect from a previous surgery, which is documented as requiring unusual effort and multiple layers of fascia repair. What is the most likely appropriate CPT code to report for the complex closure, assuming it is performed separately from the simple closure inherent to the resection? A. 49,900. B. 13,101. C. 14,000. D. 49,568. Answer A. 49,900. This question tests the advanced coding concept of reporting abdominal wall defect repair that goes beyond standard closure. The key terms are small bowel resection, 44120, and complex closure, to repair a massive defect, component separation, which suggests reporting more than simple or intermediate repair, 13101. For major reconstruction of the abdominal wall layers following a complex intra-abdominal procedure, code 49900, suture, secondary wound closure, massive or extensive, or repair of compromised surgical wound is often used to capture the extra work of rebuilding the layers when the service goes significantly beyond a standard wound closure. Codes for hernia repair, 49568, are not appropriate because the documentation describes a complex secondary closure of a surgical defect, not a true hernia repair with mesh.